this webinar about Class 1 malocclusions, classifications, etiology, and treatment. What is a malocclusion? Malocclusion can be defined as irregularities of teeth and jaws beyond the accepted range of normal. Dr. Edward Engel, who is considered as father of orthodontics, explained the first indices of malocclusion, which is based on the sagittal relation of the teeth, dental arches, and the jaws. Later, many other classifications were developed by the researchers in the field, but still Engel's classification is being used widely because of its simplicity. Engel's malocclusions are classified as Class 1, Class 2 Division 1, Class 2 Division 2, and Class 3. Engel's Class 1 malocclusion. Class 1 malocclusions are described as the presence of a normal interarch molar relationship with the mesiobuccal cusp of upper first permanent molar occluding with anterior buccal groove of lower first permanent molar. Normal relationship of molars exists, but the line of occlusion is incorrect because of malposed teeth, rotations, crowding, spacing, missing teeth, or some other causes. Approximately 60% of orthodontic cases fall into Class 1. The types of Class 1 malocclusions can be classified as crowding of teeth, spacing of teeth, transverse discrepancies, deep bite or open bite, and impacted teeth. Etiology of Class 1 malocclusions. General factors. These are heredity, congenital factors, environmental factors, endocrine hormones, and some pathologies. The heredity may be dictating tooth ratios, the relationship of the jaws, and soft tissue patterns. Congenital factors may be birth injuries, side effect of drugs during pregnancy. Environmental factors can be habits like thumb sucking or disorders in feeding style, swallowing, mastication, or speech. Endocrine hormones can cause cretinism or acromegaly, and pathologies, some of them like osteodystrophies, tumors, infections, traumas, and burns. Local factors can be divided into inherited factors, abnormalities in the size and number of the teeth, like missing or congenitally missing teeth, abnormal tooth shape and size, and supernumerary teeth. Transposition of teeth, impaction of teeth, and abnormal labial frenum. Environmental factors, premature loss of deciduous teeth, retention of deciduous teeth, loss of permanent teeth, delayed eruption of permanent teeth, failure of tooth eruption, sucking habits, trauma, local pathological factors, and displaced teeth disturbing to occlusion. Management of Class 1 malocclusions. The treatment of Class 1 malocclusions should aim to improve the aesthetics and the function of the teeth and jaws, to relieve the crowding and align the teeth within the arch, and to establish ideal COCR balanced occlusion. For the diagnosis of a class 1 malocclusion, three main orthodontic records are needed. A clinical examination by the orthodontist to check the dental malocclusion type and the general oral health. Study models on which we can make some model analysis like Bolton or Hastings, and radiographs to diagnose the sagittal skeletal malocclusion or any impacted tooth or tooth agenesis. This is the end of part 1 for class 1 malocclusions webinar. See you in part 2. Hi, in this second part of class 1 webinar, the treatment protocols will be described. I will try to explain the different types of protocols with some cases. Class 1 crowding non-X treatment. This case is a 16-year-old boy with a chief complaint of crowding of teeth. In clinical examination, we can see it's a crowding case with good facial harmony. This patient's chief complaint was his upper lateral incisors, but he was also aware of his lower crowding. The patient exhibited class 1 molar relationship with upper lateral rotations, lower incisor crowding, and lower midline shift to the left side. He had a good oral hygiene. In his panoramic X-ray, all teeth, including wisdom teeth, were present, and no abnormalities were observed. He has good TMJ health, and all the periodontal tissues look normal. Patient's cephalometric evaluation revealed skeletal class 1 relationship of the jaws, with SNA of 82 degrees and SNB with 80 degrees. Vertical dimension was good, and the upper and lower incisors were already proplined, with upper incisors 110 degrees and lower incisors 100 degrees. The aim of this treatment was to achieve a good overbite and ideal incisor inclinations while correcting the crowding. Extracting upper and lower first premolars was the first treatment alternative, but the patient did not want any extraction treatment. An alternative treatment plan was interproximal reduction. So the treatment plan was to level and align, create spaces for the crowding with IPR, and correcting the midline. Stripping was performed on upper lateral incisors and lower incisors, and following the correction of rotations, upper lateral incisors were actively ligated to the arch wire. Further proclination of incisors was prevented with chain elastics and interproximal reduction. At the end of the treatment, class 1 relationship was established, correcting the rotations and crowding. Although the smile line was acceptable and nice at the end, upper and lower lips were a little bit disturbed as the patient did not want extraction at the beginning of the treatment. Following the removal of the braces, upper and lower fixed retainers were bonded, and he was advised to have his wisdom teeth extracted. After the completion of the treatment, facial harmony was still good, Upper incisors and lower incisors were still proclined, but not more than the initial values. Here you see the superimpositions before and after treatment. The green line on the superimposition shows the upper incisor and the lower incisors, and lips were slightly proclined. Note that the lower left lateral incisor gingival healing and change after correction of the crowding. This is another case with class 1 crowding and infrapositioned canines. The patient is 15 years old and the chief complaint is the crowding of teeth. Clinical examination. This patient has a good soft tissue profile with competent lips. Her face is symmetric and she has a low to normal smiling line. Intraoral photographs show that she has slightly class 2 occlusion on the right side and the right upper canine is infrapositioned. On the left side, she has class 1 occlusion and her left canine is a little bit infrapositioned. In occlusal photographs, you can see that upper first molars are mesially rotated. This might be due to early losing of deciduous molars, and the main reason for the right molar being in class 2 position. She has also crowding on lower incisors. In OPTG, she has healthy periodontal tissues and a healthy TMJ. According to cephalometric analysis, she is skeletally class 1, slightly low angle, soft tissue profile is good and upper incisors are slightly retruded. The treatment plan: leveling and aligning, correcting mesial rotations of molars, and establishing final occlusion. These are the extraoral photographs after treatment. The lip positions and soft tissue profile did not change, and her smile photograph shows that she has a broader smile with a good gingival line. Only with the correction of molar rotations, she has a perfect class 1 occlusion. So the roots are aligned, but there is not much space for the third molars. In post-treatment cephalometric analysis, the upper incisors angle looks better. Lower incisors did not change. The molar relationship looks much better. Here are the highlights of this case. You see the molar rotations before and after, and upper teeth before and after. This is the end of part 2. In part 3, we will go on with class 1 cases with different etiologies.